rugged. I'm done trying to make y'all comfortable.
Oh, well, welcome back to the Barbell Medicine YouTube channel. I'm Dr. Jordan Feigenbaum, and this is the second part of the Toronto Q&A session that we had at our seminar from Toronto. Hope you guys enjoy. Stay tuned to the end of the video. You can learn how to submit your own form check or your own set of questions for our upcoming training vlogs.
For the rugged. Been a little too nice to y'all. Now I gotta up price for y'all. Snake guys on dice for y'all. Shoulders on ice for y'all.
The question is about high intensity interval training. Given the amount of evidence on the benefits of high intensity interval training, why did I suggest low intensity steady state is in addition to my theoretical program for general strength conditioning? I think that if somebody is doing a substantial amount of anaerobic work with a barbell, it's all highly anaerobic, and then they could benefit from a complementary inclusion of conditioning that is something different, which would be steady state cardio. The idea is that the person who is going to generate a good cardiorespiratory fitness response to barbell training, that is, they are going to achieve the ability to sustain 8 metabolic equivalents or have the VO2 max that's greater than 45, that's commensurate with decreased risk of early mortality or increased morbidity. That's the kind of threshold for cardiovascular risk. That person is going to get it from barbell training. But the person who's not going to generate from barbell training needs a different type of stress to make that happen. And I think low intensity steady state is going to be good there. And I think if we're talking about overall development of a human, just like I want you to be able to produce force, many different motor patterns at a higher level, and I want you to be able to sustain, force production for a long period of time. If you need to do that, then I think making sure somebody has a decent aerobic base is a reasonable idea. So further, I think having an aerobic base allows additional aerobic capacity to be generated, meaning that if someone only did high-intensity interval training, their ability to do anaerobic work would improve. And maybe their aerobic work would improve a little bit too, especially if they were untrained prior to that. But getting good at doing anaerobic things gets you good at doing anaerobic things, and then the ability to, that may not improve your aerobic ability, may actually hurt it, because you're not able to clear those products. So it's not just the lactate, but so the easiest example is to talk about lactate and hydrogen ion production. So in anaerobic conditioning, you're pumping out a lot of lactate, a lot of hydrogen ions. As you get better, if you did a bunch of sprints, for instance, you get better at doing sprints, get better at pumping out a lot of lactate, a lot of hydrogen ions as your sprint performance improved. The ability to clear that may not improve, and sometimes gets worse in certain individuals who need some aerobic capacity to be developed. So ideally, if you had an anaerobic athlete, you'd want to improve their anaerobic ability, but you may also need to have some low-level training of their aerobic capacity as well, so that they didn't actually get a little worse at that. So I think including that's fairly useful. And the evidence as far as the effect of aerobic training on strength outcomes, that if you don't introduce too much volume too quickly, sound familiar? I think the time cap was 30 or 35 minutes, that if you didn't go over 30 minutes or 35 minutes, that there was really no effect. And then in fact, it
has like 12 hours separated too.
Yeah, if you separate it, then the interference effect is minimized. Although I would say the most important thing is getting the volume in, especially for somebody who's not necessarily concerned with their absolute performance in the immediate future on a 1RM, 5RM. Yeah. And ultimately, if it allows somebody to train with more volume, that's probably going to be good for other outcomes. So I don't have anything against high-intensity interval training, and ideally, if I had somebody who was fairly well-conditioned, had a decent base, or was naturally at a high level of aerobic fitness or general fitness, then I would probably have them do 1 time per week of low-intensity steady state, 1 time per week high-intensity interval training, and then resistance training quite a bit. That's assuming they have no endurance-based sport that they're training for. So if I have a CrossFitter, if you put me in charge of a high-level CrossFitter, I probably wouldn't have them do hardly any actual monostructural high-intensity interval training, that is bona fide HIIT, 20, 30 seconds, 10 seconds, high-output stuff. I probably wouldn't have them do any of that. they're already doing that with their weightlifting, strength training, and their metabolic conditioning. Almost all of that stuff's anaerobic. So they're already getting really, really good at that. The complementary sort of conditioning pieces would be monostructural and low-intensity steady-state stuff. The moderate intensity steady-state stuff is best for improving your performance in moderate at that same pace. So that's the whole theory of polarized training, where basically low and slow is really good at developing this aerobic base, and then this really hard, high-intensity stuff is good at developing that hard, high-intensity stuff, whereas the stuff in the middle is best at performing things at that pace, but is also really, really stressful. Joel Friel is the guy, Friel.
That sounds very familiar.
That's the same thing with the strength training. That's why we think that 70 to 80% is kind of our money range for strength development. That's our low and slow. And then periodic exposures to 90 to 95% are kind of high-intensity stuff. And then 80 to 90% we feel like is really, really hard, really, really stressful, but doesn't produce a commensurate increase in the adaptations that we're seeking, unless the adaptations that we're seeking are between 80 to 90%. So if you were going to go to a strength competition where a 5RM was being tested, guess what? You're going to do a lot of heavy sets of 5 in that 80 to 85% range. But if you're not doing that, I don't see the benefit of sacrificing those training resources to do that. If you want to read more,
solid tangent there.
I blacked out what happened.
All right, next question.
Yeah, question is, how does getting stronger prevent mortality from cancer?
Reduce mortality.
All right, whatever. Prevent. Anyway.
I mean, you can't prevent mortality. That's what I'm saying.
Well, that's true. We're all going there. That's true.
You can't prevent
Yeah,
mortality.
we're all going there. To the best of my knowledge, this hasn't been fully fleshed out. That being said, if we wanted to theorize, there is a significant component of mortality from cancer that's due to this frailty syndrome that Austin talked about earlier. People losing a lot of muscle mass, losing a lot of weight, they become frail, they get some sort of infection they otherwise wouldn't have gotten if they had a more robust sort of physiological reserve, and subsequently pass secondary complications due to treatment. So if they're on a treatment that reduces their immune system, for instance, and they have a low physiological reserve, that's a recipe for disaster. Insert Molly Hatchet song. If you have cancer and you are unable to perform your activities of daily life because due to the medications that you're on, you have a lot of muscular atrophy, wasting, et cetera, then you need to be institutionalized where you need help, and that's increased risk of infection. Whereas if you had a higher initial strength level, higher initial physiological reserve, that may not happen to you even if you did lose a little bit of muscle mass. I view strength training as contributing to your 401k on a regular basis. Like, you don't think about it, it's annoying, people talk about it, and you think that you're doing good every time you make a deposit. It's there when you need it. That's the way I view this as it relates to cancer. I don't think that the only last thing I'll say is that when you strength train, part of the process of the remodeling, repair of muscles secondary to the stress, you get a lot of release of locally and systemically active hormones from the muscles themselves. They're called myokines. Just like there were adipokines, hormones released from the fat tissue itself, myokines are released from the muscle tissue, and there may be some effect of myokines on the cancer's process itself. That's what I would say.
Cancer is, many cancers it's a chronic inflammatory state. Just like most chronic inflammatory states, it induces anabolic resistance. Anabolically resistant, waste away. Wasting away comes with tons of complications. That's probably how I would summarize that sort of.
Is that the TLDR?
Sort of thing. The TLDR of him.
Of me,
Yeah.
as a human.
Yeah. That's all I got.
I do think it's important for people with cancer to train. And the question then would become, how do you train somebody with cancer? The same way that I would train somebody without cancer, unless there are other extenuating circumstances. If they've got a port that doesn't allow them to do certain exercises due to mechanical restriction, if they've had an amputation, if they've had a certain surgical procedure that doesn't allow them to do certain exercises, well, you work around that. You can use machines. The strength training police aren't going to show up and say, machines?
Yeah.
If they have a port that doesn't allow them to get in the low bar back squat position, the low bar police aren't going to come around and say, high bar? So I think that I would train them the same as I would train anybody else in their age-matched demographic until proven otherwise, or if there were extenuating circumstances. But I think strength training would be a good thing there.
One of the other interesting things is that candidacy for treatment for cancer, when the doctor consults with you and decides whether you are a good candidate for treatment or not, depends on your functional status, among other things. ECOG, yeah. So in addition to tumor markers and the receptors on your cancer cells and the phenotype and the genotype of your cancer cell, all sorts of very complex stuff that happens in the hem-onc world. If all that stuff looks great for treatment, but the person is already frail, they're low functional status, they're dependent, they can't take care of themselves at home, they usually don't offer treatment to those patients. I think we have a chemotherapy pharmacist here, right?
Yeah.
They might have to alter the treatment regimen. So those considerations come into play. And so that's another reason to strength train. So hopefully it doesn't happen to you, but so you're super strong and jacked and functional should you ever need to be treated for something, because it can guide treatment decisions.
The question is, are people who are on diabetic medications like metformin and or a statin, are they at any increased risk of tendinopathy or tendon rupture? Dr. Baraki, what say ye?
Nope. Yeah. The most well-established risk factor for tendinopathy in terms of medications are going to be the quinolones, fluoroquinolone antibiotics.
Ciprofloxacin.
Like you may have heard of Cipro for UTIs, for example. That one is definite. Ciprofloxacin, levofloxacin, moxifloxacin.
Avelox. Yeah.
And corticosteroids like prednisone will increase your risk for tendinopathy.
Yep.
There are numerous other medicines that are not quite as well correlated, and there's lots of debate, and a lot of this stuff has kind of some more observational data sets behind it. But quinolones, I try to avoid prescribing in general, but definitely to people who train, I don't prescribe them unless I have no other choice, which is pretty uncommon, that they're going to come in with some bug that's resistant to everything but that. And prednisone, same deal, unless I have no other choice. I do have a few patients who have to be on prednisone for various reasons, autoimmune or some other thing. And I try to keep the dose as low as possible and treat for the shortest period of time I can. But those are the medicines to be aware of. Metformin, no substantial effect on tendon issues. Statins, no substantial effect on tendon
Metformin,
issues.
you may get more jacked.
Yeah.
So that's neat. Yeah.
Cool.
The question is that it has been observed that people who rate repetition, the same RPE, will move that the last repetition at different speeds. Do we think that is reliably sensitive enough to predict where somebody is on the athletic spectrum? I don't know. My initial answer is probably not, but I have no good reason for that. Maybe. I do think that there are many inputs that go into how fast someone moves a rep, including their level of how well trained they are in that particular movement, what their emotional status is about that particular movement, the weight on the bar.
Level of arousal.
Yeah, how aroused they are. I don't mean that in the cool way. I mean that in the how worked up they had to get for the set. And then just their individual sort of training, a demonstration of training capacity at the time. So some people will move things very, very quickly. Other people won't. And I don't know if that reliably correlates to the athletic spectrum as we defined it. Maybe. And you could argue that, look, if somebody moves things really, really quickly all the time, their rate of force development is very, very high. And that might be true. And so you can make the argument that they may be further on the right side than somebody who moves everything super, super slow. The best example I have is John Patrizio. Every set that he ever does, it appears in slow-mo. But that's just him.
I think we can probably both think of exceptions. I have a client who I trained who's a medical student, and he pulled 600 for a triple, weighing around 205 or 210 or something like that, and every rep was at 10. And it just looked slow as hell. And so that makes me question the fact that I can think of people who have achieved that level of strength performance in terms of the reliability of this. There may be a general trend. There may not be, but it also probably is going to be dependent on the outcome measure in terms of athleticism, right? So we're just talking about a heavy deadlift triple. Like, yeah, we all know 600 for triple is strong. Does that make him athletic? What does that mean?
Well, does that mean I'm super athletic?
Doesn't. Yeah, right. Doesn't really.
Not true.
You know, it probably doesn't match the lay understanding of like super athlete. You know what I mean?
Actually,
but in terms of our little bubble of strength adaptation, I don't think that his bar speeds. I didn't train him any differently based on his bar speeds, how they looked when we started, and his deadlift was closer to 500 or something, whatever the case was. And so, yeah, he pulls super, super slow, but
I think bar velocity within an individual can be a fairly reliable predictor of volitional effort, and you can use that to augment your own personal rating of the exertion there. But to compare that inter-individual, I think that's unreliable. Same, just like EMG. Yeah, so I don't think you can do that reliably. Question is, opinion on prolonged sitting as an independent risk factor for certain disease states, even in the presence of regular physical activity. Rocky?
I don't know if I have a lot of opinions on that. I think I've seen some of the, at least lay public media articles that you've talked about where they're like, even exercising an hour a couple times a week may not be enough to reverse how your job is killing you and stuff like that. And I think a lot of it's couched in histrionic language and stuff like that. So I haven't necessarily assessed the evidence myself on that to have a very informed opinion. I mean, I think you have to ask the question from a practical standpoint. What do we do with that information? Do we tell people that they need to start training 24/7? Or do we think that standing desks are going to be like the cure to all of society's ills? I think both of those sound unlikely,
Well,
So, I don't know.
I know there's a study that standing for 10 minutes does improve insulin sensitivity, whereas walking didn't for 10 minutes.
Not particularly patient-centered outcome.
No, I know.
So,
but what I'm getting, and I know also that the folks in the National Weight Loss Control Registry tend to be active for 60 minutes or more per day, and then watch the least amount of TV, have the least amount of screen time compared to folks who are unsuccessful dieters. I think you could make an argument that the lifestyle of those who are the most sedentary probably predisposes folks to certain negative health outcomes, and they will end up sitting more. It's just like the people who stay in bed longer than 8 hours tend to have worse health outcomes, because if you're either more sick, depressed, or whatever, you stay in bed for a longer period of time. And then the other thing that I would say is that some of the exercise interventions are woefully inadequate to achieve the stated outcomes that we know we need to improve these things. Like, they're not getting people to that 8 metabolic equivalent threshold for cardiorespiratory fitness, or they're not actually improving their strength. There was a 12-month study where they had women bench press every week for a year, and their improvement in the bench press was less than 1 kilo. That's not a strength training program. I don't know what that is, but strength training program, it is not. And so I think that...
I bet they were using RPE.
They probably use an RPE. Essentially useless for essentially everyone. I think if you have... when the data gets more robust, what we're going to see is probably that when you don't have these goal-directed sort of training interventions that don't achieve a certain threshold, that exercise is probably not that useful if we're looking at hard outcomes. And I'd probably be on board with that. Just doing something, I very often say, is not necessarily better than doing nothing if the something doesn't achieve this minimum threshold of that level that we need. So that's what I would say. How are inroads in the medical community? Rocky?
I think that we got fortunate with the opportunities we had with Up to Date in terms of writing 2 articles for them and getting them published for the medical community. However, we cannot force anyone to read it or put that stuff into practice.
Speak for yourself.
So that was cool. However, I think that most of my experience in terms of making inroads has just been through personal interaction with my colleagues, who then either through direct conversation or from hearing from my other colleagues about me and what I do, start to ask me, and then we talk about it and I show them some of the stuff, and then I kind of work on them from that standpoint. I think that our goal in the long run, particularly as he said earlier, once we can get our seminar or products approved for things like continuing education credits for them. So we would incentivize professionals, like a bunch of the professionals that we have in the audience today, to come in order to meet their professional society guidelines and requirements, that they would learn more about it, and then would have the resources to go and spread this stuff further and kind of start more of a ripple effect or whatever across the population.
I thought you said something else.
Yeah. So I think that's the goal. So to summarize, mine so far has been within my local kind of community, and then basically whatever doctors there are also on Instagram who have come across me, and they shoot me messages actually frequently saying, I'm a doctor here and I see your stuff and keep, whatever. Thanks for the information and stuff like that. So those are kind of the places where I have directly observed some of this influence happening. But I think the more content we get out there, and particularly link it to the education stuff and incentivize it, then it'll probably grow quicker.
Yeah, I think our biggest influence so far has been in like PTs, massage therapists, chiropractors, personal trainers. That's probably been our biggest footprint so far. Getting into with more doctors, yes, the up-to-date thing, super helpful, although not
gives us some credibility to
100%.
Initiate that conversation too.
Yeah, and then also medical students. There's been just an outpouring of people who are somewhere in their medical education who want to be involved with what we're doing, or who are trying to associate with us and just trying to learn more, which is super
awesome.
encouraging. I think we're going to need a bump to make a big impact with people who are already out there in the clinic. I do think that, more content, widening our audience just in general will make more people aware of what we're doing. But that bump, if it's going to happen within our lifetime, is going to be outside of our organization. So for instance, we're going to this CrossFit level 1 MD thing. Now, I have low expectations, not because it's CrossFit, not because it's a level 1 thing, just because nobody else has gone to one of these things and then on the flip side, on the other end of their experience, they said, yep, and now I'm a consultant for CrossFit and we're helping them, move them in this direction. It's not happened before, but I'm hopeful that their audience gets exposed to us, and then our exposure. No, so this is like an invitational kind of deal. And so the idea would be that we get to meet other docs, and then they say, "Oh, Barbell Medicine, I've heard of that. I'll check your guys' stuff out." So that's just peer to peer. But then just imagine if CrossFit HQ from the top said, "You guys are the real deal. We want to, have you guys consult for us and have you out there on our huge public platform." Well, that would be a big step in the right direction for not only the audience that we already have and the groups that we're already affecting, but for other doctors. I mean, if they've got 2 doctors per affiliate, and then they've got 30,000 affiliates in the United States, something like that, that's a big number. Also, their platform just in general is exponentially greater than ours. So that would be a huge thing. I mean, why do you guys think I went on TV? I mean, yeah. Well, the idea is that if we can expose folks to barbell medicine, huge people at the amount of time, some of them are going to be doctors. And then maybe they end up Googling us, and maybe they don't get offended, with my deadlift face. And then once we made it past all those barriers, then I think we'll have done better. But I do think that we're going to need some help from the outside to get to a critical mass where I think it's going to be potentially revolutionary, even though I think right now what we're doing, what you guys are a part of, is benefiting society. But in order to make this huge change, I think it's going to need an outside push. So I'm super pumped that you guys all came. I'm super pumped that you guys are all very familiar with our material. Nobody came in here and said, "Yeah, I just heard there was like a barbell medicine seminar. I like barbells. I like medicine. Here, met seminar." Well, so nobody's here. Everybody here is keyed in, right? So that's super encouraging to me. So it means I think we're doing some good. And I do think the net benefit on society that we're making so far is net good. But in order to make this thing more than hey, do you guys know about barbell medicine? No. Well, you can check them out, and just kind of like a sideshow type deal, make it more revolutionary. Then I think it's going to need an outside push. And I don't care if my face is on the thing when it's doing good widespread, but I want it to do well across different communities worldwide. That's what I'd like to do. Yeah, I think that's going to be a tough place to get into for a number of reasons. One, because there's a lot of red tape just affecting anything within the hospital. I'm not sure if barbell medicine and the things that we're practicing necessarily improve outcomes for the shareholders in different hospitals in the United States, the way the health market currently sits. With that being said, Right now, there are a handful of CrossFit gyms within hospitals right now, and I feel like this CrossFit thing is the closest thing that we have to a real opportunity to like jump off that we could possibly be at right now. So I'm hopeful, yet my expectations are low. But we get to go to Hawaii. I mean, I get to pay for it. But Austin and I get to have a bro trip to Hawaii. So we're gonna see how this works out. I'm hopeful for that. And again, I cannot overstate this, that you guys are all very, very important to this whole movement. Every person that you talk to about this, every person that you communicate some element of this material to, even if you don't say the name Barbell Medicine or whatever, that's still very, very helpful, and that's helping us achieve our overall aims to improve this sort of lifestyle change that can overall affect health. That's our thing. That's why we're not narrowcasting. We're doing the opposite. We want to include as many people as possible. And so that's why you guys are all super, super important. We can't do this on our own.
Yeah, I think that the barriers in the hospital setting are much greater than in the non-hospital setting, at least right now. Even though I could craft a pretty good argument for this stuff in hospitals, but then I'm telling the hospital, hey, you need to resistance. I cited a paper in our article about resistance training during an acute COPD exacerbation in inpatients, improving outcomes, shortening hospital length of stay, things like that. But what that implies is, hey, you hospital, you need to hire more PTs so they can go to the acute care floor and spend more time with the patients training them. The hospital's like, why do I care about that? I don't have evidence this is going to reduce my overall costs, and I have to spend money now to hire all these new PTs. And so there's tons of barriers from that perspective. So hospital setting is very difficult, maybe way down the line. But for sure, I agree. Yeah, I'll be the BBM hospitalist. That's fine.
There you go.
But yeah, I think in the real world, you guys are super important, and you guys now have the potential. For example, with some of the things that I talked about, you can go and somebody who's in pain, and you can literally alter the course of their entire life if you introduce them to the things that they need to know, which would make my day.
Yep.
If I heard about that. So.
Social change agents.
Yeah.
Hashtag PFA. It's a great question. The question is, for general health outcomes, do we have a preferred template based on what we presented in the seminar? My default would be the 3 or 4 day hypertrophy template, probably, because it's more generalized as far as its approach, meaning that I'm not trying to specifically improve your 1RM in a squat, bench, deadlift, press more than anything else. It's got a significant conditioning component. The volume does tend to change as we would theoretically expect it to need to change over time. And it is not hyper-specialized. That's probably how I would have if someone was not a rote novice, that's probably how I would have them train. You could also do a lot worse than choosing the bridge. Again, fairly general, volume is appropriate, conditioning in there. I think the hypertrophy 3 or 4 day template would probably be my go-to on that. Yeah. Minus the errors, of course. Oh, sick.
That's fine.
Yeah, the question is, what do we think about the evidence or about genetic potential, genetics influencing strength potential, and how do we see our own training? What was the end of that?
In 30 years.
Oh, in 30 years. Oh, 30 years? I'll probably still be alive. All right. I think that there are a myriad of genetic determinants for your strength potential that influence your entire strength training career, meaning your initial response, and how you continue to respond, and your work ethic, and your ability to stick with. I think there are a lot of genetic components to that. So much so that I think when you see people who have, been a competitive powerlifter, bodybuilder, Olympic weightlifter, strongman competitor, CrossFit or whatever for the last 10 years, and I'm at a high level, these folks have you've selected for the highest level genetic contributors to performance in that specific aim. If they weren't very good at the thing, the odds of them sticking with it and then demonstrating elite level performance is pretty low. Also, just the resilience to the training load, not because, there's a genetic component to injury potentially. So I think there's a lot of genetic inputs there That being said, I don't think that strength training is contraindicated by any genetic sort of combination that doesn't produce a medical condition that would render you unable to train. Meaning that even if you're a low responder to training, you're way on the left of this training resistance, athletic spectrum, anabolic resistance scale, you should still train. Just the dose is going to be different and the prescription might be different and your outcomes are going to be less than somebody who's super sensitive to it and responds super well. That's how life is, right? And things are unfair. As far as my training in 30 years, I don't expect to be stronger than I am right now. I expect to be not as strong as I am right now. But I still expect to be training. I also expect to have more insight, more perspective on what things are important to me with respect to training. I'm in this gray zone right now. This gray zone is like, I want to be really strong because that's been my identity for a long time. Like, pulled over 700, I squat over 600, I bench over 400 regularly. I'm a competitive powerlifter. That's me to my core. If you don't like powerlifting, you don't like me. But right now I have no desire to compete in a powerlifting meet. Does that mean I'm not a powerlifter? Well, if I'm not a powerlifter, then what do? Who am I? I look in the mirror. It's not that serious. But I think 30 years from now I'll have a better perspective on things that are important to me in the gym that are independent from competition. I like competing. I used to race motorcycles at a high level, but I never liked practicing. I only liked racing. I wanted to race every weekend, as many classes as possible, as many days as possible, but I didn't like practicing. I just liked the competition. If you said, hey, do you want to go for a motorcycle ride? The answer is no, unless we're racing there. So that's kind of how I'm wired up. So 30 years from now, I expect myself to be competing in something. It's unlikely to be powerlifting unless all the rest of the competition is dead and I can win, in which case maybe I'll be back. But I do think that I'll have a better perspective on the things that are important to me with training.
Yeah, I think I'll still be training. My plan is to be, at that point, stronger than Jordan. I also plan to be competing in something. I've competed in some form of sport since I was like 5. And I don't foresee that stopping. I don't know if that's going to be powerlifting or not. I mean, when I swam, I did not foresee a day when I would no longer want to compete in swimming. And then I finished swimming and I'm like, fuck, training for swimming by myself is boring. I don't want to do this anymore. Then I found the bar and now I do this. So maybe in the future I'll be competing in something else. But yeah, I'll still be training. And I think even more than looking forward to any particular thing relating to my training in 30 years, I look forward to knowing more things.
Oh, yeah.
Filling my brain with all kinds of other things. And hopefully we're still teaching and influencing people, and hopefully more people, can go around spouting off quotes like "pain is an output of the brain" and things like that. So
Baraki cool. said the Baraki theory.
Yeah.
There's already the Feigenbaum constant. I didn't make that up. So
yeah, different Feigenbaum.
Different guy apparently.
So,
all right. Really, thank you guys for coming out. I really appreciate it. Thanks.
All right, thank you so much for watching the Barbell Medicine YouTube channel. Hit like if you dug the video. Make sure to subscribe for all the latest content. If you have your own form checks or your own questions that you want to see answered on our vlog, send us an email, media@barbellmedicine.com. There's a description below about the requirements for what you need to send. And as always, thanks for watching. Catch you guys next time.
Lab on me going all the way. For the record, ain't trying to link, no time to waste. For the record, yeah. For the record.